Hello, everybody, and thank you for coming to be in this session. I know there's a lot of competing priorities during this time. So I'm pleased to present on behalf of my colleagues in Asia. We have struggled to provide lifelong therapy to perinatally infected children and adolescents. Early in infancy and childhood, there may be drug resistance associated with PMT-CT treatment, and then later in life, our patients face adherence difficulties in adolescence. Within Asia, there are many countries with accessible second-line antiretroviral options, but third-line drugs are inaccessible or extremely expensive outside of compassionate use programs. We definitely need more data on second-line regimen durability, failure, and resistance if we are to better understand how and when to switch from second-line. The study we implemented was aimed at evaluating immune and virologic responses, adherence, and resistance mutations in those who are already on or switching to second-line regimens, as well as assessing susceptibility to third-line drugs if those were needed. We included children who had been infected in early childhood as long as they were under clinical care at participating sites. The switch criteria required a major class change for what local clinicians considered was treatment failure. We excluded children who had been exposed to initial mono or dual NRTI regimens, whose first failure was a triple nuke combination, and who switched for reasons other than treatment failure. We also excluded those who are on non-standard regimens, specifically those who are on once-daily lopinavir and on mono or dual therapy with only protease inhibitors. After enrollment, children were assessed every 6 months up to a maximum of 120 weeks. If failure was identified at a threshold of 1,000 copies on a single test, samples were sent for genotyping and therapeutic drug monitoring. Viral suppression was based on being below the lower threshold of the local assay, which ranged between less than 20 to less than 400 copies. We evaluated adherence using pill counts and visual analog scale. Analysis of risk factors associated with failure was also conducted. Between March 2011 to December 2012, 277 children were enrolled at 8 sites in Indonesia, Thailand, and Vietnam. 12% were switched at enrollment and 88% were already on second line. We were able to collect retrospective clinical and lab data for most of these children during the time since second line switch with some limitations. The analysis was restricted to the 274 children on whom we had at least 6 months of follow-up data. Patient characteristics are showed here for the time at second line switch and at the last study visit or virologic failure. A little less than half of the patients were females who were a median of 7.5 years old at the time they switched from first line. Less than half were in WHO stage 3 or 4 at the time of switch. All of our patients had failed NNRTI-based first-line regimens, and almost all went on to start boosted lopinavir regimens. The 20 patients not on lopinavir were on atazanavir. At the time of switch, all patients had been on ART for a median of 2.7 years and had a CD4 of 300 cells, or 13%. At the last visit, or viral failure, the median time on ART was 3.6 years. The CD4 had risen and the viral load had fallen, but these numbers reflect a combination of patients who were both suppressed as well as those who had failure. This Kaplan-Meier graph shows the probability of viral failure after switching to second line over time, with years post-switch on the x-axis. Overall, 73 patients, or 27%, had at least one viral load over 1,000. The median time on second line to first viral failure was 2.4 years, with an incidence of 7.3 per 100 person years. This table describes the viral failures after second-line switch, and as none of the patients were switched to third-line regimens during the study, we were able to monitor them and document a second viral load test over 1,000 in 40 of the 73, and then a third elevated viral load test among 23 of the 40. The sex distribution mirrored the female-to-male ratio in the overall study population. The median age was 11 to 10 years at the time of the elevated viral loads. The median CD4% at the time of viral failure was 22 down to 15%. The median viral loads were about 4 log or higher, and the time on second line was about 2.5 years up to 3 years. 4 were on atazanavir, and the rest were on lopinavir. Between 52 to 73% had pill counts reflecting over 95% medication use, and visual analog scale reports over 95% adherence, although all of these patients had elevated viral loads and met our failure criteria. As some of the patients had their first viral load before study enrollment, only a subset had plasma available for therapeutic drug monitoring, which was done for the protease inhibitor in their regimen. About 1/4 of those with available TDM, or 16% of all patients with viral failure, had drug levels below the lower limit of quantification. Almost all patients with the second viral load over 1,000 had TDM samples available, and half of them had no quantifiable drug in their plasma sample. This was similarly the case for those who had a third elevated viral load. With regards to genotyping, we had genotypes for about 70% of those with one viral load over 1,000. For the second elevated viral load, we had 75% and 87% for those with a third elevated viral load. This figure shows the mutations that were detected after the first elevated viral load in blue, after the second elevated viral load in red, and after the third in gray. The mutations are categorized into having more than 6 lopinavir mutations, any major lopinavir mutation, any major atazanavir mutation, and any major darunavir mutation. The percentages of those susceptible to lopinavir by the Stanford interpretation are at your far right. Overall, there were low levels of resistance detected. Looking specifically at the major lopinavir mutations at the first elevated viral load, 8% had a major mutation, and this was almost the same on the second elevated viral load and went to 15% for the third. Between 80 to 86% of those with elevated viral loads remain susceptible to lopinavir throughout. This slide shows the NRTI resistance at second-line viral failure. And what I wanted to point out is that across the board for pretty much every mutation, the mutation rates are much lower than what we found at first-line failure. And specifically, for example, the M184V is reduced by about 40%, the number of TAMs similarly by about 40%, which I think also reflects the lack of the very poor to non-adherence in our patient population. There were 2 covariates found to be independently associated with failure: age at second-line initiation of greater than 11 with a hazard ratio of 4.1, and viral load at second line of over 5 log with a hazard ratio of 2.4. Sex, duration on first line, weight, height, clinical stage, and CD4 were not significantly associated with failure. Unfortunately, we were not able to include adherence in the Cox model because we were missing adherence data for those who started second-line regimens before study enrollment. In summary, 70% of our patients were able to maintain virologic suppression over more than 3 years of study follow-up. But of those with a viral failure at the 1,000 copy threshold, only up to 15% developed major mutations to second-line protease inhibitors, even after up to 3 elevated viral loads over 1,000. And half of the patients with 2 or more elevated viral loads had unquantifiable protease inhibitor levels, showing that the repeat viral failures and the low levels of observed resistance were frequently related to very poor or non-adherence and limited drug pressure on the virus. Moreover, it appeared that visual analog scale and pill count were not reliable indicators of adherence when compared to viral load and TDM in those with failure. However, we also observed that those with only a single elevated viral load were able to resuppress their virus. Our findings emphasize that we need more adherence support for those who are repeatedly experiencing viral failures in order to prevent worsening resistance. Viral load testing helps us to identify those at risk, but we need more effective and adolescent-specific tools to motivate them to take their medicines. We would like to thank our patients, study staff, and clinical laboratories at the participating sites, Azar Karmini at the Kirby Institute for her help with our retrospective data, and our funders at VIV Healthcare, the US NIH, and AIDS Life. Thank you very much.